Ladies and gentlemen, welcome to join this Gilead-sponsored symposium entitled Ending the Asia HIV Pandemic by 2030. What's the next step? I am Chien-Ching from National Taiwan University Hospital, Taipei, Taiwan. I will be joined by two panelists, Professor Choi from South Korea and Professor Liu from mainland China. This is our agenda. We will talk on the 2030 targets and 95 status in Asia, followed by a discussion on the barriers to 2030, achieving the 2030 targets and the strategies to overcome the barriers. I would like to invite the audience to feel free to provide your comments and questions. And at the end of the symposium, I would like to invite you to provide your feedback to improve the quality of our symposium in the near future. These are the disclaimers. According to the UNAIDS estimate, there were 5.8 million people living with HIV in Asia in 2020. In 2020, there were 240,000 new HIV infections. Overall, we have been making significant progress over the past decade in Asia Pacific region. Here you can see, compared with the 2010, there was a 21% decline in new infection and 56% decline in AIDS-related mortality. To achieve HIV elimination, UNAIDS has set ambitious goals. The first one is to improve the access to HIV testing and prevention to cover 95% of those individuals in need of combination prevention and services to eliminate vertical transmission and a woman with access to sexual and reproductive health services. The second is to improve access and linkage to HIV treatment and retention in care to cover 95% of those with HIV infection, to diagnose 95% of people living with HIV, and those diagnosed, 95% of them start antiretroviral therapy. And for those who start antiretroviral therapy, 95% of them achieve viral suppression. And moreover, 90% of the people living with HIV and at-risk population have access to treatment, a patient-centered and context-specific integrated care. The third is to elimination of health inequalities and stigma and discrimination, trying to reduce the stigma or any punitive law against people living with HIV to less than 10% of the countries. And 10%, less than 10% of people living with HIV experience a stigma and discrimination. And less than 10% experience gender inequalities and violence. To accelerate the progress toward the 95 targets, we need to review the current landscape of HIV testing and care and to identify the barriers and challenges to reaching the target set for 2030. In this table, you can see the current achievement of the 95 targets in Asia Pacific region in 2020 was 76, 84, and 95%. Here you also can see the current achievements of these three targets in China, Taiwan, Korea, and Thailand. There are significant variations across the Asia Pacific region. So we need to try to identify the barriers and try to identify the strategies to overcome these barriers to achieve the targets in our respective own country, particularly during the COVID-19 pandemic. I would like to invite the two of you to share your experience in reducing the stigma surrounding the HIV testing. Are there any sort of strategies to reduce the stigma surrounding the HIV testing in mainland China?
I think it's a very sophisticated phenomena of stigma or discrimination of this kind of disease. In China, I think some very famous stars, and they go to the media or some TikTok and to show their how to say their empathy or their love for this. They don't have any such a stigma of this HIV infection. They can show their capacity or their how to say they can embrace our patient, and they can there is no risk of living together with our patient. So I think that might have a good influence for our public education. And the second thing is that our professional doctors, we can teach, we can give some very good education for those patients. And there, for example, something that if we live together with the patients, we don't need to alert more things. We can live together with them, and all those patients, if they have very good treatment, and they can live longer as normal human beings, such like this. So, and the third, I think in hospitals, for example, as I am a ID doctor, I know some knowledge of this disease, and I will tell other physicians, for example, the surgeons and my colleagues from other departments. I'll tell them that HIV/AIDS is no longer such a threatened disease, and if they can have very good hygiene, some good defense, they can do surgery for all these patients. So I think the stigma will be eliminated for those reasons.
Thank you. I think the stigma or discrimination often originate from misinformation, misunderstanding, either from the healthcare workers or general population, or even among the family members. Sure. I just want to ask Professor Choi to see if there are any sort of strategies to reduce the stigma surrounding the HIV testing. I know that the experience in Thailand, they have the key population that HIV testing. I'm sure that the key population would share their experience with stigma or discrimination from the society or from the general population or even from the healthcare workers. I just want to know if any such kind of key population that HIV testing exists in Korea.
In Korea, implementing of anonymous testing and self-testing kits distribution were very helpful for improving testing rate in MSM populations, but stigmatization is very for MSM population is very strong in Korean society, so it is very hard to increase testing rate among MSM groups. It is important hurdle for HIV testing rate in Korea.
So it sounds like the self-testing should be promoted in this region to avoid or to reduce the risk of stigma or discrimination surrounding the HIV testing. I know that in China, the e-commerce has been widely accepted. Is it possible or is it ongoing that the e-commerce is also involved with the distribution of HIV testing kits?
Yes, I think all those anonymous urine tests, I think they can be available online. For example, in Taobao such app, and the youngers or the patients who they want to test, and they can buy it, and also they can buy it from some other electronic stores. I think the problem is that if they get positive results, or if they get negative results, what they can do afterwards. And sometimes even I think there appeared some false negative results, but if they don't have knowledge what symptoms they have, they should go to hospital to get HIV antibody or Western blot test. So I think the more knowledge we should provide to this person, and we don't rely on they just get the test from online. I don't think it's a good choice, but it can be as a pre-screening strategy.
Yeah, thank you. Professor Du mentioned a very important point of the raising or promoting the awareness about the HIV infection and the treatment, the current status of the update on the HIV treatment. Now we are going to move to the treatment recommendation for HIV. So first, I would invite our panelists to give us the update on the HIV treatment guidelines in mainland China and South Korea, and followed by Taiwan. Professor Du, please.
Okay, I think we have just published our latest Chinese guideline for diagnosis and treatment of HIV/AIDS. It was called 2021 edition. In fact, it was the 5th edition of Chinese guideline for HIV and AIDS since 2005. In this new Chinese guideline, I think we have included not only those international up-to-date evidence, but also including some Chinese own research data. So I just show this slide for recommendation for initial regimen for adults and adolescents with HIV. In this Chinese guideline, and we have some highlights. The first, we just recommend rapid or same-day antiretroviral therapy start strategy in this guideline according to our availability of those single tablet regimen. And also in this guideline, we have written more details in monitoring of viral load and monitoring of CD4 T cell, and to avoid early viral failure of those patients. And also in this guideline, we up to date some PrEP or PEP, some recommendation. So I think this guideline, since this guideline was published last October, and we have started it, and then we I think make some symposia on how to educate some patient, some physicians from very remote areas, and they can do some individualization treatment for our patients. For example, if the patient they don't have a very good economic condition, they can get free drugs. And if the patient have insurance, social insurance, they can choose a simple tablet regimen. And if the patients, they can get some more drugs, they can pay for some drugs. And I should mention that since this year, all the drugs, I think, were covered from social insurance. For example, Biftaf, I think the price was lower, very much lower than before. So our patient, they can get very good drugs since this year. So that this guideline, I think this new guideline can change our some concept. We can recommend the patients to choose the therapy as they need or individualized. And also in this guideline, we emphasize that we should make more long-term management of the patients for longer time, and we shouldn't only emphasize the CD4 or viral load. We should keep more focus on their organ management for a long time. For example, the kidney function and the hepatic function, and also some psychiatric disorder, for example, etc. All this long-term management. So that's what I just mentioned to you, our new Chinese guideline.
Thank you, Professor Liu, for updating the ART guidelines in mainland China. Then I would like to invite Professor Choi to give us an update on the ART guidelines in Korea.
Korean Society for AIDS updated clinical guideline for HIV diagnosis and treatment in 2021. The updated guideline included guideline for diagnosis or ART for naive patient or ART for experienced patient, and ART for tuberculosis co-infected patient or pregnant woman, and so on. For treatment regimen for naive patient, Korean guideline recommend ART combination with INSTI, integrated strand transfer inhibitors. INSTI-based regimen is recommended for most treatment naive patient. Especially single tablet regimen is most popular regimen for HIV treatment naive patient. Because all the cost for HIV treatment is fully covered by government in Korea, so cost is not a problem in Korean people living with HIV. For when to treat a chapter, it is recommended to start ART on the same day of diagnosis of HIV infection, or as early as possible after diagnosis HIV infection. It is revised guideline for when to start ART. This is it.
Okay. Thank you. I'll share with you the HIV treatment guideline update in 2020 in Taiwan. The ART combination with the 2-NRTI plus another antiretroviral agent is generally recommended as the first-line therapy. But because there are higher rates of pre-treatment resistance association mutation to non-nucleoside reverse transcriptase inhibitors here in Taiwan, and also the lower or a very low rate of the pre-treatment resistant associated mutation to integrase inhibitors from our previous surveillance studies. So the integrase inhibitor based regimens are often the preferred recommended first-line therapy. And because of the previous finding of a very low resistance associated mutation to integrase inhibitors, so the we don't need any resistance testing before initiating integrase inhibitor-based regimen. So these are the ART treatment guidelines in Taiwan. And moreover, both of you already talked about the when to start antiretroviral therapy. And in Taiwan in 2018, the government recommended to start antiretroviral therapy within 7 days of HIV diagnosis. And then in 2020, the government introduced the rapid confirmation of HIV diagnosis with the introduction of immunochromatographic testing, which could provide the HIV confirmation within 30 minutes. Pretty much similar to the Western blot Professor Liu just mentioned, but it could be performed and had the result within just 30 minutes. So with the introduction of the immunochromatographic testing, we were able to confirm the HIV diagnosis in any individual who were screened to be HIV positive. And so in 2021, the government recommended same-day antiretroviral therapy for any individual who had the confirmed HIV diagnosis. So since both of you had mentioned about the rapid or the same-day antiretroviral therapy in this era of INSTI-based regimen, I would like to ask you to share your experience with the rapid ART or same-day ART initiation in either mainland China or in Korea. Professor Liu, would you mind giving us your experience?
Okay, I think a rapid antiretroviral therapy or even same-day antiretroviral therapy, I think this new concept in mainland China have been accepted even from those guidelines. For example, your EACS or DHHS or WHO guidelines, they prefer this new concept. So I think in this Chinese new guideline, we just write this rapid ART into this new guideline. I think there's still may exist some barriers in all mainland China. And as I said, China, we have a very big country and we have different gaps in different areas. But in my hospital, I'm working in Peking Union Medical College Hospital, and we have a very good test. We have Western blot, and we can test viral load, and we can get the results just during 7 days, and can ask the patient to fulfill all the tests. So I think the rapid ART, even sometimes I will give patient same-day ART. I think it's possible, and for some areas, maybe for some health centers, they don't have very quick examination. They cannot give the patient very good or very fast examination. I think there might be some barrier for them to practice. Even though I think the patients they accept this concept, and if they can get accessible for those drugs, for example, integrase inhibitor drugs, for example, BIFTAF, and they have very effective effectiveness and high effectiveness, and also low resistance, and they don't need to test other, for example, HIV 5701, and they don't need to test resistance. So I think they might be accept this concept and practice more. I think for the same day ART, just as Professor Hong mentioned, if we have a very good test, as you said, then we can confirm the HIV status at the same day, I think we can practice more same-day ART.
Thank you, Professor Liu. Professor Choi, would you share your experience with the same-day or rapid ART initiation? Given there are also recommendations from the Korea guidelines on ART initiation. Thank you.
For clinically symptomatic HIV people with HIV or sexually active people with HIV, I definitely recommend same day or early ART for those patients. But sometimes for asymptomatic people with HIV, I may delay the initiation of ART after getting viral result of viral load and resistance testing. Delay in viral load and resistance testing is one hurdle for rapid ART. Turnaround time in my clinic for viral testing and resistance testing is usually about 2 weeks or 3 weeks. So it is a kind of barrier for rapid ART initiation. But in Korea, the retention in care rate is very high. In my clinic, follow-up loss is very low. So for asymptomatic sexually inactive patient, sometimes I may defer the initiation of therapy after getting viral load or resistance testing.
Thank you, Professor Choi. Do you have any sort of consideration when, or any specific consideration on the ART you're going to choose for any individual who are going to be put on antiretroviral therapy? Since you just mentioned the resistance testing, are there any other concerns that probably might delay the ART initiation?
The rate of resistance mutations for integrated transfer inhibitor is very low, almost 0%, around 0% in Korea. So for rapid initiation of ART, we can consider ART regimens with high resistance barrier and low resistance mutation rate. INSTI-based regimen is especially bictegravir, tenofovir, and emtricitabine would be one option for rapid ART initiation. Another point is activity for hepatitis co-infected patient. Tenofovir and lamivudine has activity to hepatitis co-infected patient. For rapid initiation, we do not need to get the hepatitis result, even in same-day treatment situations.
Okay, thank you. I just want to ask Professor Liu whether the chronic hepatitis B will be a major concern in mainland China when you're going to choose an antiretroviral therapy.
Yes, I think in mainland China, I think nowadays we have a less percentage of the co-infection HIV and plus HBV, but it also should be concerned when you start the ART for the patients. If you don't know the status of HBV and just choose some antiretroviral therapy who cannot cover the HBV infection, and maybe the patient will suffer from later HBV reactivation or something hepatic function failure, something like that. So if the drug like Professor Choi said, if the drug contains those regimen who can cover HBV, I think you cannot concern about HBV co-infection. Another thing I want to mention is that the adherence. I think very good adherence is the best. It's the best thing for very good ART. Even the patient take some we say the older regimen. So if you start rapid antiretroviral therapy, the single tablet regimen would be a very good choice to start the rapid ART, and the patient can have a very good adherence. So you don't concern about the later miss tablets or something like that. So 1 tablet per day is a good start, and you can persuade the patient to take it as soon as possible.
Yeah, thank you, Professor Liu. And we just mentioned about the healthcare workers or the HIV treating physicians' concern, and I would like to invite Professor Choi to sort of share your experience with the people living with HIV. What were their concerns about initiating antiretroviral therapy?
I think concerns on side effect would be major concerns of people living with HIV who start ART. So considering their concern, the safety profiles of ART would be very important for rapid initiation of ART.
Yeah, thank you. And I will share with you the rapid and same-day ART initiation in Taiwan. This was a retrospective study aiming to see the outcomes of the same-day versus rapid ART initiation between 2018 and 2021. This was study conducted among 12 hospitals around Taiwan. And in the left lower panel, you can see the rate of same-day ART initiation indicated by the blue bar increased from 2018 to 2021, suggesting that initiating ART on the same day of HIV diagnosis has been increasingly accepted by the healthcare workers and the patients themselves. So in this study, we assess the outcomes indicated by the transfer, loss to follow-up, or retention in care, and the virological responses to ART initiation. This study excluded those people living with HIV who had concurrent cryptococcal meningitis or TB meningitis. And even they have sort of pneumocystosis that could be included in the study. So you can see that the rates of loss to follow-up between these two groups. The first one is the same-day ART initiation. The second group is the rapid ART initiation. That is initiating ART between the second day to 7 days of confirmed HIV diagnosis. And you can see that the rate of loss to follow-up has been similarly low, about 2.7% to 3.4%. And the viral suppression at week 4, week 28, as well as week 48, the rates were similarly high between these two groups, suggesting that because there are concerns about the readiness or preparedness of the patient themselves to start antiretroviral therapy. So our study suggests that initiating ART on the same day did not scare the patient off, and the rate of retention in care remains very high. But it's really not the only the antiretroviral therapy that play a very major role, particularly the single tablet regimen containing integrase inhibitor that is easy to take and had good efficacy. The important part is to provide support to the people living with HIV when they first receive the HIV diagnosis. So we have currently in Taiwan, we have the case managers the case managers cooperate with healthcare provider or HIV treated physicians in supporting or navigating the individuals with HIV. So we provide support, counseling, and assistance they need when they learn their HIV diagnosis. So after a discussion regarding the benefits of antiretroviral therapy and the HIV, what HIV is, or HIV infection, how HIV infection is treated, and the current update on the HIV treatment, all those information will be provided or will be discussed between the case managers, healthcare providers, and the patient themselves. So within this, with those support, the great majority of the people living with HIV could start antiretroviral therapy within 7 days of diagnosis, or even on the same day of HIV diagnosis. And then we will proceed with the discussion on the lay presenters and lay initiation of antiretroviral therapy, and to see if two of our panelists have any experience with the lay presenters and lay initiators. Yes, first I will ask Professor Liu to share your experience with the lay presentation or lay ART initiation in mainland China.
Okay, I think late presentation, last year, I think we held a very good symposium on this topic. What are those late presentation or late presenters in mainland of China? And from CDC data, we have roughly nearly 30% of patients who might be late presenters or who have CD4 less than 200 when they when they come to hospital to initiate their ART, which means they might come to hospital maybe after a long time of HIV positive testing, or maybe they one day get tested and they have a very late stage. So maybe there are two situations for them. So for these late presenters, I think it's a very severe phenomenon, and we should make more focus on those patients that maybe during the last before they initiate ART, they might be the population who have transmitted the disease to others. So I think we should start ART for them as soon as possible. So I think that for those patients, if they delay their ART initiation, they might be transmitters, and also maybe not good for our epidemic control. So for these patients, we back to the first topic, we should enlarge the HIV testing and to explore those patients at the first stage is better, and then avoid they going to the late stage. And the other thing that we should ask all those patients who start in ART as soon as possible, and to decrease the transmission.
Yeah, thank you, Professor Liu. Professor Liu mentioned very important aspects regarding the reduced in the lay presenters or lay presentation or lay ART initiation. Professor Liu talked about the improved access to HIV testing and linkage to care, and also as we, the HIV treated physicians, needed to try our best to retain them in good care. But there are always concerns or consideration from the healthcare of the people living with HIV. I would like to ask Professor Choi to share your experience from the any specific consideration from the people living with HIV, which may lead to the lay presentation and lay ART initiation.
As you know, early ART and early diagnosis and early treatment is the best cost effectiveness way to prevent HIV transmissions. So early diagnosis and treatment is very important for society. But I performed a study on the change of rate of rate presentation in Asian countries. The data show that the rate of rate presentation is not decreasing for almost 10 years. So we must do many effort on the to improve the rate presentation problems in Asian region. But I don't know the specific method for improving this problem. But we have to do efforts such as decreasing stigmatization or distributing self-testing or many effort for improving this problem.
Yeah. In Taiwan, I think they're well properly similarly observed in many Asia Pacific countries or regions. People living with HIV may still have misconception, misunderstanding, or misinformation from the websites. So when in Taiwan, particularly in our hospital, we link the HIV testing with the HIV treatment center or clinics. And when any individual seeking voluntary counseling testing service, when they were found to be HIV positive, we will ask our colleagues, the case managers, to provide support immediately on the site to support them. And then we will explain what HIV is and what the treatment is. And the very important part is that we show the drug, the tablet, to the patient, and to ask the small tablet could control the HIV infection very efficiently, and as particularly the single tablet regimen. And with this demonstration of the treatment, it's just to clarify how the treatment has been updated and has been progressing. So because they usually have misunderstanding that the treatment will be quite complicated and associated with many short-term or immediate adverse effects. So with those information provided, we're able to sort of dissolve their concerns or misinformation regarding the HIV infection and HIV treatment. Yes, because of the time limit, we have to close this symposium here. I would like to thank our two panelists and the audience to participate in this symposium. I hope that through the discussion today, we all could learn from each other and to provide the most good care to people living with HIV, to those individuals affected by HIV. I understand that we may not be able to cover all those aspects related to HIV testing and care. So, so I would like to invite our audience to submit your questions and comments on the aspects of HIV management, and you can put it in, write it in the chat box. Please feel free to share your comments, and your feedback is very important to improve the quality and the contents of our symposium. So I would like to invite our audience to provide your feedback and to complete the post-meeting survey by pressing the survey. Thank you.